Good evening, sir. Dear doctor, it is with great pleasure that we extend a warm welcome to Dr. P C Mahapatra, a distinguished gynecologist and passionate teacher renowned for his expertise in the field of women's health. Sir, during insightful and illuminating discussion centered around the intricate topic of abnormal uterine bleeding. With his extensive experience and profound knowledge in gynecology, his presentation promises to shed light on the complexities, diagnostic approaches, and contemporary treatments regarding this prevalent health concern affecting women globally. E-Gurukul series 4 serves as an invaluable opportunity for gynecologists to delve into the nuances of this abnormal uterine bleeding, gaining comprehensive insights and fostering a deeper understanding of this crucial area in women's health. We eagerly anticipate Sir's enriching discourse, which undoubtedly will contribute immensely to our collective understanding of this significant aspect of gynecological health. Welcome, sir.
Thank you, Dr. Sefali, for a fantastic introduction of the E-Gurukul series and overestimating me as a speaker in this particular series for that. Thanks all the team Juventus under the leadership of Alad and whole team, the medical team present over here. Well, reminding our E-Gurukul, it has become a stimulus to me by my fellow delegates, my fellow viewers, all gynecologists. I must compliment you and salute you for the response and stimulus you are constantly providing me for continuation of this E-Gurukul series in education in the field of women's health in gynecology and obstetrics. Well, series 1 has been started and completed about 28 episodes dealing with the surgical skill transfer on the various aspects. Next is the series 2 has started, and this is the 4th episode of solving clinical dilemmas. Well, obstetricians and gynecologists are that group of medical fraternity. They deal with every type of elective to emergency from adolescent to menopause, and really they are the healthcare provider of not only women but from creation to cremation. I think hats off to you people, the viewers who are with me today in this episode. And in this episode, I always bring the blessings of Lord Jagannath. I'm nobody, I do not know anything about the subject, and he and she guides me all throughout that. Next. Well, therefore, this particular series, I think, thanks to the team Juventus for continuing this E-Gurukul program, and welcome to the series 2. And here, today I will be dealing with a very important and a common topic day in and day out a gynecologist faces: abnormal uterine bleeding. I think there is a lot of changes in the concept of abnormal uterine bleeding because of the evolution and I think the conceptual changing trends in the conceptual knowledge, in the reproductive endocrinology of understanding, and the diagnostic gadgets of the imaging sciences. There has been a tremendous amount of changes in the diagnosis and as well as the management, particularly in the case of abnormal uterine bleeding. Well, once upon a time, it was really a clinical dilemma. Until today also, our gynecologists, including me, face clinical dilemmas day in and day out. The common problem, because of the common problem in OPD, you people must be seeing every day. You must see a very common disease, abnormal uterine bleeding, presenting by the patients from all age groups, and at times it becomes a clinical challenge and really a confusing state for the gynecologist as far as formulating the treatment for that. And therefore, I bring you something on a clinician's perspective and solving the clinical dilemmas on a very common topic. You all are aware of this term abnormal uterine bleeding, but there has been a lot of changes in the various concepts which I will highlight. There is changes in the diagnostic armamentarium, and of course the management protocol now has become a different concept which is to be communicated by you, because science is growing and technology is advancing, and the concept is also changing. And I think it's a time to be keeping pace with all this if you are really doing a really scientific or really something which is based on evidence for that. Well, these are the hard facts in abnormal uterine bleeding. And what is an abnormal? That means there is a normal uterine bleeding. Normal uterine bleeding is nothing but eumenorrhea or normal menses. Any deviation from this abnormal, the normal menses is known as abnormal uterine bleeding. Is as simple as defined. And uterine bleeding, normally, what is the outcome? How normal uterine bleeding occurs? It's a complex outcome of interactions between systemic hormones and an end organ, the uterus, starting from the hypothalamus, pituitary, ovarian, and the end organs. May be physiological changes, may be pathological changes. It culminates in abnormality for that. And it is a spectrum of dysfunction and array of manifestations. The varieties of manifestations could be there, and the dysfunction could be in various forms for that. And presentation in three main groups in the woman's life, starting from adolescent, reproductive age period, and perimenopausal age groups. I think this is very important for the clinicians to segregate into these three different categories, because the different presentations are related to different spectrum of the diseases, and the treatment modality varies from adolescent to reproductive period and perimenopausal age group. And that's why we must define which group is important, but particularly the abnormal uterine bleeding for that. Abnormality, when we say that abnormal uterine bleeding, there are two components, either this abnormality in cycles or in abnormality in the flow. The cycle length is 1 in the normal menses, and the amount of flow is normal in the normal menses for that. And when the cycle length is within the 28 days plus minus 7 days, it is considered as a normal. And flow, the subjective and objective analysis is important, and more importance has been given to the amount of flow, and that has been distinctly decided that 85 ml is considered as a cutoff limit for the normal amount of flow in one cycle for that. Either it can continue for the longer period. If the longer period with the scanty bleeding, that can be amounting for more than 85 ml, or within the reasonable period, within 1 or 2 days bleeding also, it may have a severe bleeding, that is does also considered as a normal for that, abnormal. So therefore, it has to be basically decided, and the clinician should have an impression, and taking history, the clinician should give importance to this particular pattern of the abnormality in cycle or flow, or a combination of all these. This could be a combination of abnormal flow with the abnormal cycle for that. Now, the definition of normalcy, what is a normal flow and all that? As I've already told, it is either a subjective or an objective. Subjective meaning by that a woman is having habituated to particular history starting from the menarche, and she considered that this is normal for me. And if it is deviating from that, then she says that it is abnormal. Objective meaning thereby the amount of flow, The amount of flow, either you can measure it, amount of flow. The amount of flow can be measured by the total of the pad weighing or pedometry, and when it exceeds the 85 ml, then we consider that is abnormal. In other words, we can, from the history, we can tell that if the amount of blood is there, it clots. Many people like it. Normally we say that whether you are having amounts of clots passing by the menstruation, if the clots are there, that means it signifies that the normal amount of liquefaction of the blood is not there. The amount of bleeding is more, so that it is not able to liquefy, and therefore the clots is there. So it is presumed that when there is a clots, the amount is almost more for that. Again, when it continues for a longer time, it reflects the hemoglobin status, and from there we can correlate that yes, from the history we know that it is abnormal, the bleeding is more, and on hemoglobin is also low. That means we must correlate this, that this could be related to the menstrual abnormality. Now, significant lifestyle issue as well as health risk. This is a really abnormal uterine bleeding gives rise to a lifestyle issue as well as health risk for that. Lifestyle issue is also important, reflecting on the abnormality in this the flow or in the cycle, and the brightest example is increased BMI. Increased BMI, particularly, this gives rise to abnormal flow or abnormal cycle length for that. And if the flow is more, it also reflects the health risk and amounting for the anemia and its consequences on the general health issues for that. Heavy menstrual bleeding accounting for 2/3 of all hysterectomies. If you say particularly incidence of hysterectomy, we know that the incidence of hysterectomy prevalence is much more nowadays. And this could be, if you analyze the total number of hysterectomy, the 2/3 of all hysterectomy are due to heavy menstrual disease, either a pathological or a pathological entity. And more often, you ask yourself, have an introspection, that are we not abusing the hormones in the treatment of abnormal uterine bleeding? I think hormone abuse is more often in 99.9% of the cases for that. So therefore, the purpose of this E-Gurukul is that I will share some of the basic things where you use your hormones, which type of hormones, how many days, what is the route, and where not to use a non-hormonal treatment for that. And that is most important. And use, abuse, and misuse of hormones is more common in this particular entity for that. Understanding the pathology, pathophysiology, and clinical correlation is very, very important for vital to the day-to-day clinical practice. Unless we understand the pathophysiology of this and have a clinical correlation, our treatment is not scientific, our treatment is not rational at all for that. And therefore, we cannot ignore, in the era of technology, we cannot ignore the clinical sense. So tech versus touch. The thoughtful history taking, judicious use of investigative tools, and rational treatment protocols are the really scientific and rational approach to the case of abnormal uterine bleeding. Well, abnormal uterine bleeding, as I have already told, it could be cyclic or it could be acyclic. It is not fitting to any cyclic pattern. Acyclic. And the cyclic pattern, I've already told, to emphasize more. Once again, I must say that it is a disorders of cycle, disorders of flow, or in combination for that. I've already told about the disorders of the cycle length. The length of the cycle, 28 days, is taken as an average, where plus minus 1 week, 7 days. From 21 to 35 days, we consider that this is normal. Before 21 days, it's a more frequent cycle. And after 35 days, it is an infrequent cycle for that. There are various nomenclature which have been used already. And Varis and Neri classification was there when we were students, and we were in the early part of my teaching. I was just teaching students about the Varis and Neri classification, where distinctly some of the terminologies has been defined, like a menorrhagia, like a polymenorrhea, polymenorrhagia, metropathia hemorrhagica, and intermenstrual metrorrhagia, and these are commonly being used for that. Now, subsequently, the recent diagnosis, the recent nomenclature has almost completely abandoned this previous nomenclature, and it's become very simple in a literary way, either a frequent menses or an infrequent menses or a scanty flow or intermenstrual bleeding. To have a better understanding of this subject, these terms have been more closely applied. In addition to HMB, heavy menstrual bleeding has become a distinct entity for that also. And therefore, there has been a lot of changes in the FIGO guidelines has already been changed. I remember 2004 FIGO meeting. I was one of that part representing my country, and therefore I'm well aware of the formation of the menstrual disorders committee, and therefore they've changed the complete definition of the abnormal uterine bleeding. And second important is an acyclic bleeding. It's not related to any cycle length, and when any acyclic bleeding is there, you first think of local cause. That should be the clinician's temperament and thinking, and that is to be first ignored and first excluded before undertaking any diagnostic procedure for that. Well, little bit about this particular nomenclature, like dysfunctional uterine bleeding. We were for years together. We were teaching dysfunctional uterine bleeding to the students. It is a very common disease. It comes in theory. It comes as a long question. It comes as a short question. And in exam also, in clinical, day in and day out, we ask in all examinations about the DUB. And at that time, dysfunctional uterine bleeding has become a category of definitions which is changed. Now, some of these people have defined initially that abnormal uterine bleeding in absence of pregnancy, inflammation, and tumor. This is the definition of Virchow, which is given long back. If pregnancy condition is excluded, inflammation is excluded, or any tumor, and if there is nothing, we say that abnormal uterine bleeding for that. And for the clinicians, we always say that any abnormal uterine bleeding in absence of any clinically detectable pelvic pathology, and on examination we find that there is no pelvic pathology, we can say that is a case of dysfunctional uterine bleeding. But to exclude the detectable clinical pathology, it is the only clinical parameters that is being applicable, and it's not that laboratory or any investigative methods can be applicable for that. Now, Jeffcoat has clearly defined that is the definition of this is abnormal uterine bleeding in absence of organic disease of genital tract. He defined that there should be organic disease should not be there, and genital tract. Definition of the genital tract as per Jeffcoat is that the genital tract starts from the ovary. It's not always say that it's technically ovary should be excluded from the genital tract. It's a fallopian tube, uterus, cervix, and the vagina. These are all included under the genital tract. But for the sake of definition of the DUB, ovary, genital organs is also included here in absence of. There should not be any abnormality in absence of organic disease of the genital tract. So, and what is the meaning by organic disease of the genital tract? Simple explanation is that suppose we find that there is an abnormal uterine bleeding, we do an endometrial sampling, we find a non-specific endometritis. Then it is considered as a DUB. It comes as a tuberculous endometritis. It is an organic disease. Then we exclude that is not a case of DUB for that. Meaning thereby that the concept of DUB and definition of the DUB was that it is not related to any organic disease of the uterus, cervix, vagina, fallopian tube, and the ovary for that. But now with the changing concept in the definition, I think should it be obsolete? Now we have changed our pattern of education that dysfunctional uterine bleeding should be obsolete from the definition of the abnormal uterine bleeding after the FIGO classification, which has really solved the issues of that DUB, and only we consider as abnormal uterine bleeding by the clinician's parameter for that. And therefore, the FIGO has given this definition. Menstrual Disorders Committee was formed in 2004. I still remember the FIGO meeting when I was there in Geneva. That abnormal uterine bleeding, the definition is a very simple definition and a clinician's definition, which is very important for the gynecologist. Palm coin classification in FIGO. In a palm coin classification, they've devised and palm and coin, two different things. One is a structural lesions, another is a non-structural lesions. Palm polyp, adenomyosis, leiomyoma, malignancy, and pre-malignant conditions for that. And coin, coagulopathy, ovulatory disturbance, endometrial, and something idiopathic or unexplained variety, and these are all neoplastic, pre-neoplastic condition for that. Palm coin classification FIGO has been accepted by that. This gives a very clear idea and about the classification in comparison to our Wallis and Nery classification, in comparison to the DUB, which is there for that, or heavy menstrual bleeding has become a different entity on that part for that. But mainly now all clinicians' approach must be directed whether it is a structural lesion in the polyp, adenomyosis, leiomyoma, or malignancy, or a non-structural lesion completely dependent on either an endocrine ovulatory disturbance or endocrine disturbance or coagulopathy, and these are all on unexplained variety. These are all included under the non-structural lesions for that. This is simplifying the clinical criteria and really satisfying the clinician's perspective for that. Now, endometrial pathology was considered as one of the most important criteria as far as the treatment part is concerned for that. And the number one is abnormal pathology. When it's abnormal pathology, main purpose of doing an endometrial pathology, why you do an endometrial pathology? There are main purposes that in all cases you did not do an endometrial biopsy. All cases, say for example, in endometrial and adolescent UB, we do not require the first stitches and not a first setup for that. Neither in the case of reproductive age for that. It's more important for a menopausal bleeding, and therefore this is either to exclude abnormality. Number one, first and foremost, to exclude malignancy or any infective, and more so in country like ours, tuberculosis is a common cause for that. And if it is normal, what are the normalcy? We must explain regarding the normalcy, and basing on that, the treatment modality will depend on that. Normal, if you do an endometrial sampling, you come as an atrophic endometrium. Then we say there is a senile endometritis. So atrophic endometrium it could come, or a proliferative endometrium it could come, or secretory endometrium come, or hyperplastic endometrium. These are the four varieties of abnormality come non-pathogenic. It's a non-pathogenic. Pathogenic is either malignancy or tuberculosis. And non-pathogenic endometrial status, either atrophic endometrium suggestive of senile endometritis, proliferative may be of early proliferative or irregular proliferative. Secretory could be early secretory, late secretory, irregular secretory. And we have read earlier about the irregular ripening and irregular shedding related to the secretory pattern for that. Either it could give rise to a premenstrual spotting or a postmenstrual spotting, depending on whether it's an irregular ripening or irregular shedding, meaning thereby it is related to corpus luteum abnormalities. Persistence of corpus luteum is irregular shedding, and early function, premature function of the degeneration of the corpus luteum is known as an irregular ripening for that. And therefore, these manifestations of secretory could be there. In hyperplastic, it could be a simple hyperplasia or a complex hyperplasia. Simple hyperplasia with atypia or without atypia. Complex hyperplasia with atypia or without atypia for that. And this atypical or complex hyperplasia with atypia is a pre-malignant condition, which is very, very important in exclusion, particularly in perimenopausal women for that. So what does it mean? The treatment modality, endometrial biopsy gives an idea about the treatment modality. All abnormal uterine bleeding doesn't require hormonal treatment, doesn't require progesterone, which day in and day out we prescribe that, and our gynecologist did routine prescription for that. So for the understanding of my clinicians, you must be very much correlated with the basic pathophysiology. As I've already told and hinted, we must find out if it is an atrophic endometrium and there is a bleeding. Either the bleeding, you don't give anything, otherwise you don't give any hormones, or if at all you give hormones, it's a combination of estrogen with progestogens. It is not progestogens. If tons and tons of progestogens is not going to help in this atrophic endometrium. I think these are all either a non-hormonal measurement, or you give a hormone combination with this. And if there is acute bleeding, therefore the estrogen is mainly prescribed for that. Primarin and parenteral primarin was prescribed, particularly for atrophic endometrium, non-responding to any medical measures for that. In a proliferative endometrium, what is lacking? It's early or irregular proliferative endometrium. The secretory changes is not there. That means it's a progestogen lack is there. So the treatment modality will be the progestogen in a cyclic manner. Either is from 16th to 25th day or from 11th to 25th day for that proliferative. And if it is or the second is a COC, which can be given from the 5th day of the cycle for 21 days for that. If it comes as a secretory endometrium, early secretory, late secretory, and irregular ripening, the corpus luteum insufficiency or corpus luteum excess. The main modality of treatment, which is irregular treatment, again COC could be a drug of choice. But if it is a late secretory, it's normal. What is the treatment? If it is a late secretory, the non-hormonal treatment is the drug of choice, that tranexamic acid, NSAID, or armiloxafen could be a treatment for that. And if it is a hyperplastic endometrium, simple hyperplasia, that means unopposed estrogen, and therefore progestogen is the treatment for that. It varies from either a 6 months to 9 months treatment for that. And if it's atypia is there, it's a pre-malignant condition, and therefore surgery will be the first line of modality than medical management. And of course, if you stick to the medical management, I think the preventive oncology, the progestogen in the parental progestogen can be given in this particular variety for that, or the local LNG IUS can be preferred for that. But if it is associated with the corpus cancer syndrome, like a diabetes mellitus or a obesity or hypertension, these are the cases where the surgery will be the first line of management over medical management. So the message which I must give it, that endometrial pathology, every clinician does, but start treatment without seeing the reports of that histopathology. At least see the report of the histopathology, exclude malignancy, exclude infective disease, and if it is a normal, what type of normal endometrium you find out, proliferative, secretory, or hyperplastic, and then you decide whether which hormone or non-hormone or surgery or a medical management. That will be really a scientific a rational criteria or rational with evidence we are treating it, and there is some rationality in the treatment pattern for that. Now coming to the diagnosis, history, age, duration of abnormality, amount of bleeding, symptomatology like associated pain or some other abnormality we can find out, any pregnancy state, any drug history, these you must take in the history. And clinical examination, you do a general examination. In general examination, you apart from seeing the anemia, you must see whether there is a skin rashes, ITP, suggestive of some abnormality, or either a malignancy or idiopathic thrombocytopenic purpura. You do a per speculum examination except in the adolescent. You do a detailed clinical examination. In adolescent, you restrict it. Either you can do a PR examination for that. Otherwise, the per speculum examination and PV examination is really important for that. I must say one thing, that these are the cases people, we should not ignore the speculum to put it for that. Abnormal uterine bleeding, of irregular uterine bleeding. I think a speculum examination is a mandatory thing for that. It's a habit of clinicians to prescribe hormones starting from the taking a history, patient is bleeding, you do it for that. And particularly if you are insisting on the telemedicine, I'm reminding you of the corona period where the telemedicine is there. People have used tons and tons of progesterone for bleeding for months together. And when I say that I will see the patient putting a speculum, I find either a myomatous polyp, and which can be twisted within minutes and bleeding is controlled with that, or it could be a malignancy, an advanced stage which could have been diagnosed much earlier for that. So the significance of per speculum examination, particularly in a reproductive age group, particularly in a perimenopausal age group, is mandatory. You cannot but avoid this clinical examination and only depend on the imaging sciences for that. Need for EUA examination under anesthesia is also important, and quite often many of the cases where we find that yes, you are not able to examine, mainly in a case of resistant case or non-responders, in a case of adolescent AUB, where the bleeding is continuing, you are giving hormones and the bleeding is not controlled for that. I think there is a place for examination under anesthesia. You can do a vaginoscopic examination and you can find a polyp, a myomatous polyp or endometrial polyp protruding through the cervix for that, or you can do a hysteroscopy and find out that there could be a lesion, the submucous myoma, which is being treated for that. Need for UA is also important for that. Apart from it, the complete hematological evaluation has to be done, and complete endocrine evaluation. I think all cases do not require a complete endocrine profile for that evaluation. We give importance to the thyroid status. Thyroid and women are so closely linked with that, and therefore the thyroid status has to be done. Particularly a single estimation of a TSH, not a total thyroid profile, will help in that particular. But don't do unnecessary all investigations, endocrine starting from FSH, LH to DHEA and all that. It's not absolutely necessary for that. Now, sonography has become a great boon. And nowadays with the changing concept or changing, evolving technology of a man and machine, these are really good machines have come up, which has really given rise to intricate lesions in the cavity, intracavitary lesions, which can found out for that. Sonography, the TVS particularly, is a very valuable tool for that. In addition, you can put a color Doppler, and this imaging science sonography, I must say that the machine has become really a next generation, recent generation of machine with the artificial intelligence incorporated with it. I think it's super. The lesion can be found. Earlier, prior to that, for time being, we were doing a contrast sonography. We were pushing the fluid and finding and detect the small myoma or a small polyp. Now with the 3D scans and with the current generation of machine, we can clearly evaluate every details of the cavity abnormality or the myometrial abnormality or the ovarian abnormality with the transvaginal sonography. So this is an invaluable aid, and I hope majority of the gynecologists are very excellent sonologists for that, and they themselves can do it and clinically correlate it so that the accuracy will be much more better for that. Apart from it, the color Doppler, CT, MRI, when as and when required, can be a supplemental for a diagnosis thing for that. Now coming to the endoscopic evaluation, and more so in an abnormal uterine bleeding, we must find out what is the cavity abnormality. Hysteroscopy is really an important parameter for that. But in hysteroscopy is really an invasive test. It's not a non-invasive. As far as possible, if information we are getting it by sonography, hysteroscopy could be relied on the therapy. But for the diagnosis, when the sonography, there is a doubt about it, or they are not able to diagnose, I think hysteroscopy is absolutely an important criteria for diagnosis of this abnormal uterine bleeding, more of in a case of peri-operative bleeding. And of course, the endometrial sampling, which is there for that. I've already told about the endometrial sampling, and all cases do not require the endometrial sampling, particularly the endometrial, the adolescent and the reproductive age group. But in perimenopausal age group, it is absolutely mandatory for that. So after diagnosing, what are our aims of management? First and foremost, confirmation of a diagnosis and put into it whether it's a structural lesion or a non-structural lesion, whether it comes as a palm or a coin lesion for that. And nowadays, the leiomyoma gradation has been there from 0 to 8 also. And that has also to be segregated. If you guys revise this classification of palm leiomyoma, IUBL, as starting from 0, meaning that it's completely with the pedicle, it is there inside the stuck. 8 means pedunculated subserous, and in between depth of invasion or amount of myoma present and encroaching in the cavity, and in the intramural component, it is divided into these 2, 3, 4, 5, 6, and 7. Now, first and foremost is a confirmation of diagnosis. Second important is arrest of bleeding. You must arrest bleeding for that. Third important is that maintenance of cyclicity. This is more important, particularly for adolescent and reproductive abnormal uterine bleeding for that, and exclusion of malignancy or exclusion of any pathological lesions or any the abnormal histopathology is to be detected in the case of perimenopausal bleeding for that. And last is prevention of recurrence. You give a treatment and how to prevent the recurrence for that. So therefore, the clinicians should have in mind 3 main aspects. We know that there are 3 periods in the woman's life this abnormal uterine bleeding occurs: adolescent, reproductive age, and perimenopausal age group. And the fundamental rule, the mantra is that in adolescent, we always a tendency that we focus attention to the uterus and pelvis for that. But in adolescent, when there is an abnormal uterine bleeding, exclude coagulation disorder. In reproductive age group, exclude pregnancy state, like incomplete abortion or post-orbital bleeding or gestational trophoblastic neoplasia for that. And in malignancy has to be excluded in perimenopausal age group. So adolescent coagulation disorder, reproductive age group, pregnancy states, perimenopausal age group, malignancy. Now the treatment therefore differs in 3 distinct age groups for that. In adolescent, more of medical management has to be there, and in reproductive age group also medical management is more often employed for that, excepting some of the pathological states. And of course, when we find any pathology, either a medical management or a surgical management has to be employed for that. Apart from it, general management is important. If you find that the patient is having a bleeding and anemia, correction of anemia is a very important parameter for that. And the total management will vary either in the medical management or a surgical management, depending on the instances or the cases which you diagnose, whether in the palm coin group for them. So in the general management, the correction of anemia is very, very important to have corrected, because this reflects the anemia status, the patient bleeding, excessive bleeding. Now, lifestyle issues is more important in a case of abnormal uterine bleeding, not with excess flow, but the scanty flow or more of infrequent cycle for that. It is more common nowadays with adolescent and some cases of reproductive age group, where the lifestyle age group, the obesity, the BMI is completely related to the flow and the cycle length for that. And that has to be corrected for that. The role of thyroxine, as I already told, in endocrinological parameter relationship with the thyroid is very, very important, and thyroxine, particularly for a case of hyperthyroid state for that. And hematological management is important when we find an hematological abnormality, excluding the anemia, other causes of hematological management or hematological disease, if you find it, like an ITP, von Willebrand's disease, or some of the coagulation disease, I think the hematological management is important. And in there, you have to take a consultation with the hematologist for that. And out of all this, apart from the general management, medical management, surgical management, the counseling is a very, very important part for that. I feel that the counseling is more important in adolescent. Commonly presenting adolescent girls with abnormal uterine bleeding. Number one is that their psychological conditions. You see, for the think about her psychological condition. A young girl in the first menarche, heavy menstrual bleeding, and there she is really apprehending, and she's afraid of menses. What is this? And she's really having a averse with the menstruation, which is a basic physiology for that. This is number one. Number two, the counseling of the mother. Mothers of this adolescent girl are really worried, not for the bleeding, either more or less. They are worried whether my daughter will be pregnant or not, even at the age of 12, 13. She thinks about that, whether the reproductive capacity will be affected by this amount of bleeding for that. And therefore, the counseling of mother as well as the patient is very, very important for that. Now, majority of this abnormal uterine bleeding, I think more often it is tackled with the medical management, and therefore life without knife. That's a first concept we must give it for that. And some cases where it's necessitating surgery, I think surgical management has to be done for that. So in the first component, I will just deal with the life without knife, and there's a medical management for that. Let's go into the details of it. What are the medical management? Non-hormonal management is one, and hormonal management is another. I think then specific molecule, some specific molecule for that medical management is there. And therefore, the non-hormonal management has a definitely a place. And here the NSAIDs and antifibrinolytics, tranexamic acid has become really a regular prescription in a case of abnormal uterine bleeding before us as a clinicians for that. And these are the cases I've already told that when we find, if we do a biopsy also, without doing a biopsy also in adolescent and the productive age group, any abnormal bleeding is the first line treatment for that tranexamic acid. And in a case where we give a tranexamic acid, particularly in a case of non-hormonal treatment, in the case of perimenopausal bleeding, see that it is a secretory and normal late secretory bleeding. I think there is no place. Progesterone is normal, estrogen is normal. And what is the rationality? That rationality is some of the non-hormonal treatment of tranexamic acid, which is more appropriate for that. Ormiloxafin, a research molecule from India, I think this has become also in use for that, although not very commonly used, but still in cases of resistant cases, avoiding surgery, where surgery is not contemplated, patient is of high risk. These are the cases. Ormiloxafin is also tried in a selected group of individuals for that. But remember that long-term use of ormiloxafin is really a doubtful value for that. And the main problem of ormiloxafin, I have seen that people have used it for ormiloxafin for 6 months or 1 year, and they do a review scan. They find endometrial hyperplasia. And they're worried that this ormeloxifene is giving problem in endometrial hyperplasia for them. But ormeloxifene is causing endometrial. If you find a sonography, endometrial thickness will be around 18 millimeter, 20 millimeter. But what it causes in endometrium, there are two things. One is a stroma, another is a gland for that. So ormeloxifene is not affecting the gland, and it affects this stroma. Stromal hyperplasia will be there. So therefore, overall the endometrial thickness will be increased, but there is no proliferation of the gland, which is detrimental for a pre-malignant or malignant lesion for that. People are scared that it's a malignancy. No, it's not that. In many cases, I've also done an endometrial biopsy, and you don't find a biopsy specimen. It's scanty tissue. This is really a paradox. When you find a sonography that it's a hyperplastic endometrium, and on examination on biopsy, you don't find a tissue. And it signifies that it's a stromal hyperplasia. It's not a glandular hyperplasia. In a glandular hyperplasia, you find plenty endometrium, whereas in stromal hyperplasia, we do not find this. So this is an ormeloxifene could be an alternative management in a case of AUB for that. But the hormonal management, majority of the cases, we usually contemplate with the hormonal management for that. So progestrogens is the first line of management because it's a very good hemostat. Uterine hemostat is a progestrogen, the synthetic progesterone derivative, and more commonly the 19-nor testosterone derivative. In the 19-nor testosterone derivative, we have really a potent progestrogens, which is a really good uterine hemostat, and that is a norethisterone or a norethisterone acetate. Norethisterone acetate is 3 times more powerful than norethisterone because the nuclear retention time is 3 times more than the plain norethisterone for that. And therefore, progestrogens has become a first-line treatment, particularly for abnormal uterine bleeding for that. Estrogens. As I already told, plain estrogens was being used and recommended particularly for atrophic endometrium, in a senile endometritis, in a perimenopausal bleeding or a postmenopausal bleeding, where progestrogens is not the treatment. And if the heavy bleeding is there, this can be really arrested by estrogens or estrogen progesterone combination. But in majority of the cases, even if you don't do any treatment, you do an evaluation, you find there is atrophic endometrium, leave it as such, and automatically it will be controlled with or without annexation for that. Otherwise, estrogen and progesterone combination are most important for the abnormal uterine bleeding. Androgens, when we were students, androgens injection were lot of used, testosterone injection was being used. I think it is not being recommended now as a treatment modality for hormonal treatment. Neither the danazol for them. Danazol and androgens has gone to graveyard, particularly for endometrial, for abnormal uterine bleeding and endometriosis for that. GnRH analog, yes, this could be some role for that in GnRH analog or GnRH antagonist, which will come in the near future for that. These are the drugs which can be used for arresting the bleeding and to build up the patient, to build up the hemoglobin status in a case when you find that there is a submucous myoma, a grade 0 or grade 1 myoma. And here in abnormal uterine bleeding, and the hemoglobin is about 6-7 gram%. There is a place to arrest bleeding, and either these are not responding to the normal conventional 19-nor steroid. There you give a GnRH analog, it will arrest the bleeding as well as reduce the size of the myoma for that. So this is one place where a temporary period you can give it for that. It's not for permanent solution for that. LNG-IUS has become a very contributor and important therapeutic regimen in a case of abnormal uterine bleeding, more so in the reproductive age group as well as the perimenopausal age group for that. We can save a lot of uterus by this particular LNG-IUS, and this is very important and very effective also. Originally, LNG-IUS was really designed as a contraceptive method, a very good long-term temporary method of contraception and reversible contraception. This main aim was to have that contraceptive effect. But we have seen that because the LNG-IUS, the local progesterone secretion of 20 microgram a day and local effect on the endometrium causing an endometrial atrophy that is going to, in majority of the cases, that has solved the problem of heavy menstrual bleeding and converted to either a normal cyclic bleeding or a menorrhea or a scanty bleeding for that. So in cases, this could be a very good alternative for hysterectomy. And in many cases, it is a very important thing, and all clinicians are very happy with this. But only thing is that one must diagnose that is a case of ovulatory and is a case of endocrine disturbance, which is giving rise to that. There is no pathological thing, and malignancy or pre-malignant condition is not there. Submucous myoma is not there. So LNG IUS could be preferred in that particular instances. And there are specific molecules now designed. There are some specific molecules like ulipristal acetate. In a case of myoma, ulipristal acetate could be there and used for that. And for the timing, for some period it was in abundant from market because of the hepatic damage failure, but now it has again revived ulipristal acetate. But long-term use is also recommended now. But initially it was recommended for 3 to 6 months. If the long-term use is there, periodic liver function has to be done for that, LFT. So this ulipristal Dynogest. Dynogest is also a very good drug for endometriosis manifesting with the abnormal uterine bleeding, or adenomyoma, adenomyosis manifesting with bleeding and pain. Both can be dealt with the new generation of the progesterone. These are all progesterone, selective progesterone receptor modulator, Dynogest for that. And others like a mifepristone. Mifepristone has also been used either as a substitute or an alternative with the ulipristal for a cases to myoma, a multiple myoma, and is a cheaper drug. 25 milligram of the mifepristone can be used for either a short-term or a long-term use for immediate arrest of bleeding or subsequently avoiding surgery for that. So coming to the progestogens, therefore, which forms the main drug for medical management for that. The type is important. Which type of progestogens can be used for that? 19-norsteroid, I've already told, norethistron acetate, and levonorgestrel intrauterine device. These are the common thing. And of course, for maintenance and cyclicity, we can use the medroxyprogesterone for that. And next is a combination with the estrogen component. A cyclic component can be given for that. So in varieties of progesterone can be used for that, starting from the levonorgestrel to the norethistron group to the combination with the estradiol. I think ethinyl estradiol 30 microgram is the lowest IMIs, and combination with that the progestogens, and starting from the levonorgestrel, norethistron to the Dynogest combination, we can use the progesterone component for that. Nowadays, progesterone component and all that, the third generation or fourth generation of the progesterone receptor modulator had been involved in combination with the estrogen for that. But the pure progestogens, very good hemostat, first and foremost is a norethistron acetate and then norethistron. These are the two main agents for the effective uterine bleeding, arrest of the uterine bleeding, and medroxyprogesterone could be a secondary drug for that also. Now, these are the types, and the dose varies starting from, normally if you use a norethistron and norethistron acetate, it is available with the 5 milligram, and controlled release with either a 10 or 15 milligram controlled release for that. The main demerits of controlled release is that there is a chance of breakthrough bleeding in there. Otherwise, the simplicity of using once daily is enough for that. But if bleeding is more, normally we require about 10 to 15 milligram daily of norethistron, and therefore initially we prescribe for 5 days, one tablet 5 milligram thrice daily, then 5 milligram twice daily for 15 days. That will immediately arrest the bleeding, particularly for that, and then think of continuation or maintenance of the cyclicity for that. So this would be the dose of progestogens for that. And the route is always oral. And the duration varies. The duration varies, particularly in a case of adolescent abnormal uterine bleeding. The combination of these two, estrogen and progesterone combined, can be given, or initially to arrest bleeding, only progesterone or estrogen can be given. One cycle and immediately post pubertal abnormality, pubertal abnormal uterine bleeding. It is a self-limiting and short-term use of maximum 3 cycles can be enough for that to control and reverses the normal cyclicity for that. Now come surgical management, and nowadays the conservative surgery, either a conservative surgery or doing a radical hysterectomy, the radical surgery like hysterectomy, simple hysterectomy. In the conservative surgery, now endometrial ablation or resection, many have been tried for that, the resection, hysteroscopic resection or endometrial ablation. First is about the efficacy, second is about the long-term complications. So efficacy, resection, a skilled hand is required for that, or endometrial ablation. I think every skill will have an endometrial ablation for that. And the efficacy is also varies. Resection gives a better efficacy than the endometrial ablation for that. And of course, the only thing is that a good skill, why I'm telling you, complete resection of the endometrium is important for that. If there's an ectopic site which is left behind, they will give rise to secretions and persistent dysmenorrhea will be there for that. And second important, if at all the malignant change is there in the remnant endometrium, I think the manifestations will be too delayed in a case of endometrial malignancy because of the resection. The pent-up blood and the malignancy will be remaining there, which could have been diagnosed much earlier with the warning sign of bleeding for that. Myomectomy is really a day in and day out. Every gynecologist faces it, and it depends on whether it's an abdominal myomectomy or a laparoscopic myomectomy or a hysteroscopic myomectomy or a vaginal myomectomy for that. So these are the cases of conservative surgery. And the more radical, if you do not want an organ preservation, and therefore hysterectomy could be there for that, then the decision will there. The gynecologist, first route I will recommend a vaginal. Vaginal will be the first route, second will be the laparoscopic route, and third would be the abdominal route. And therefore, I prefer in this sequence, no hole surgery, keyhole surgery, and a big hole surgery for that. In that sequence, depending on your skill and the expertise and the training which you do it, these are the routes. There is a changing trends and changing techniques for that. And really, it could serve the purpose. And this is important, particularly cases where there's a pathologic, like a myoma is there, non-responder to medical management, or in a case of pre-malignant condition, like a complex hyperplasia with atypia, or even complex hyperplasia without atypia in a corpus cancer syndrome, where the first line management is surgery, not the medical management for that. And of course, if you find a pathology like a myoma, you have to deal with it, either whatever route you find out for that. So number one is that if you're going for a hysterectomy, the genuinity of indication should be there. It's not a need of the patient. It's a need of the patient which is important, not the mood of the surgeon for that. And therefore, priority has to be decided. The clinical judgment will be varying on the patient profile and on your own experience, because no dogma in science. I always do a laparoscopic hysterectomy. That means all cases I'll do by laparoscopy. I always do a abdominal. I'll do by abdominal, or I'll do vaginal in all cases. That is a dogma. No dogma in science. What is best for that patient, particularly as far as the efficacy is concerned, as far as the safety is concerned, you decide that route for that. Now, this is a case, a simple example. I've already shown it, many of these on hysterectomy by my previous surgical skill transfer. There's one case I'm just giving, always vaginal give importance. There's a case of adenomyosis, or in the case of multiple myoma, it's very easy. And these are all vessel sealer along with the cutter. And we do it with that so that you see that the average size about 12 weeks, 14 weeks size uterus, and without any adhesions and all that, and can be tackled very well with minimal blood loss, with minimal time. Hardly it takes about 15-20 minutes for that. And post-operative conditions is very, very good, and people can recover it with that, particularly for that. So this is one route, vaginal hysterectomy. I'm just showing for that. Now, this is a case where there is a FIGO grade 2 myoma uterus, and is encroaching to the endometrial cavity. You find it's not the whole majority, the 2/3 or 3/4 is inside the intramural component, where normally the hysteroscopic myomectomy is the method of choice for that. And in hysteroscopic myomectomy, you take a precaution, particularly if the pregnancy is wanted in reproductive age group or in adolescent. Don't try to remove more of endometrium. You skip the endometrium, go and scoop the endometrium, make a hole and find out and explore. And you can very well find out the cleavage. You can find out that which is the muscle and which is the myoma. And this could be very well explainable for that. And you can clearly delineate the margin and then complete the procedure. You can do it one sitting or two sittings, whatever you like, but don't injure more of the endometrium and complete the procedure of removing that. And really, it's a beneficial thing for that. And these are all cases where it is a previous surgery with the adenomyosis, not responding to the medical management, tons and tons of hormones has been given and all that. There is an extensive adhesions for that. And there we go for a laparoscopic hysterectomy for that. So these are the cases where laparoscopic hysterectomy can be a solution for that. Now coming to after all these discussions and theoretical discussion, let me cover the second part is about the situation analysis, because solving clinical dilemmas is my priority. And therefore in this series of episodes, I will focus on the clinician's perspective and the common condition, how you solve it for that. Number one, case one. It's a young unmarried girl of 16-year-old. It's a very common presentation by all of you must have seen that. And 16-year-old girl, bleeding PV off and on for last 1 month. Bleeding PV is there for 1 month. They present with that. And what should be the clinician's approach? A clear-cut, a very good history has to be taken for that. Since how long she's having a menarche, whether this bleeding, what is the previous menstrual cycle, whether it's a normal or abnormal, all these has to be taken from the history. History of any medication, history of any rashes or bleeding gums. I think these are a very important thing in the history, pertinent history taking. And then you go for the physical examination. The physical examination of this particular thing, apart from manifesting the clinical evidence of anemia, you must find out whether the petechial rushes pertaining to any coagulopathy for that or any malignancy for that. And then some investigations has to be done. What are the investigations has to be done? Minimum investigation is a CBC. You have to do it. A platelet count has to be known for that. Degree of hemoglobin status has to be known for that. And at least an endocrine evaluation, do a TSH for that. So these investigations, apart from it, you can do a scan, pelvic scan for that, because in unmarried, this transvaginal sonography, although is recommended to have a clear delineation of the endometrial cavity in the adolescent girl, the abdominal scan is enough for that, so that you do some investigations and then reach at a diagnosis and exclude any pathology for that. And the treatment, what is the treatment modality, you must say that. Now, first about the history, you must find the previous menstrual history, history of any missed period, bleeding from other sites, as I have already told, any treatment history, you must find out for that. And then on the physical examination, again, I have to say about the general physical examination, the bilge, the pallor, the thyroid abnormality, the ecchymosis, and the abdominal palpation, any mass. Internal examination, at best, you can do a PR examination for that. And in investigations, as I've already told you about the hematological investigations, you must do it. Biophysical, that means a sonography and a transabdominal sonography is permissible for that. Not a endocrine evaluation is necessary, excepting doing a TSH, the thyroid status for that. And endoscopy, say no to endoscopy. In the initial setup, when it came with the bleeding for 1 month, because you have a hysteroscopy, put it. No, it's absolutely a big no, and a contraindication for that is only indicated where it is not responding to the medical treatment for that. And then and there, you start a specific treatment. If you find a cause, you can find a cause of myoma, you can do a specific treatment. Otherwise, straight away start a hormonal treatment. And in the hormonal treatment, and with the combination of normal like tranexamic acid, is a common adjunct and a therapy with the hormonal treatment. with the general supportive treatment of correction of anemia. That's important for that. And correction of anemia has to be done for that along with the supportive treatment. Now, if you consider the hormonal treatment in this particular case, progestogens, again, I'm telling that progestogens is the first line treatment because it's a potent uterine hemostat for that. The 19 norsteroid derivative or norethisterone or norethisterone acetate has to be given for that, and the type is decided. Dose I've already told about 15 milligram initially, then 10 milligram, but 20 days to therapy is important. In many cases, with the first 20 days, it stops, and the next it is self-limiting, it continues. And in case you require maximum 3 cycles of treatment is enough for that. Don't use more of that. And many people say that the progestogens which are using is androgenic for that. So we are giving a short duration of 3 months therapy is enough for that, and build up the patient with the iron for that. Now, place of COC, whether there is a place of COC there or not. If there is a previous abnormal menstrual history, say for example, more of infrequent menses, and the amount of bleeding is there, irregular cycle could be there. You can combine with the place of COC. Combination of estrogen, low dose estrogen of 30 microgram is to be given, because thinking about the epiphyseal closure at the age of 16 years, we don't want to give more duration. 3 to 6 months is enough for that. Don't give more of that. So place of estrogen, there is no absolute contraindication, but the progestogens is the only, mainly the first line management for that. Danazol, say no to danazol. Others, you can combine with the tranexamic acid along with that. So the take-home message, adolescent AUB is a common occurrence, and exclusion of hematological abnormalities, thyroid abnormality, organic lesion of the genital organs is the essential for management. Progestogens is the first line treatment for that, and more so the norethisterone and norethisterone acetate. And the 2 components you must think about: how to arrest the bleeding and maintenance of therapy. At least if you give it a 3 months therapy, it is a self-limiting hypothalamic pituitary ovarian maturity will be there, and subsequently and cyclicity should be maintained for that. But in a non-responders, you must exclude local lesions. In a non-responder, as I have told, bleeding is continuing, it is not responding to progestogens. I think there is place, think about local causes for that, and you can do and find out, and either as the endocervical polyp or endocervical myoma, or myomatous polyp or endometrial polyp, which needs a treatment at the OPD, I think a very minor level, but with the anesthesia for that. General supportive care is essential, as I have told, correction of anemia. The correction of anemia is that it is an iron deficiency anemia, and treat with iron. And the treatment of iron, either oral iron, if we are willing, or there is a definitely a place for parental iron for that. There are many advantages of parental iron like FCM nowadays, and FCM has become a really an expanded horizon of treatment of parental therapy of iron, which with one single dose of 1000 milligram, it can be corrected, and then it takes part of the reserve also, tissue iron for that. So general supportive care is essential for that. And then last is that I've already told, counseling of adolescent girl and mothers. Let the girl not think that this is detrimental. I will not think that menstruation is a pain. It's a pleasure for that. And therefore, this mental makeup has to be done, and the counseling should be done for that. Case 2. This is another, again, adolescent 17-year-old girl having infrequent and scanty cycles from menarche every 2 to 3 months and bleeding for 1 or 2 days. In scanty cycles, therefore scanty. I must say one thing, that objective assessment of scanty is less important than the subjective assessment, in contrast to the heavy menstrual bleeding. Heavy menstrual bleeding we can know and we can measure, that is 85 ml and all that. There is no strict criteria what should be the lower limit of the bleeding, whether it's a 5 ml or a 10 ml. Normally 20 to 30 ml is there for that. If it is a 20 ml, less than 20 ml, we can say that it is abnormal uterine bleeding. I think more importance is given when we come as a scanty menses is more subjective than objective assessment for that. And this girl is having both scanty flow as well as 2 to 3 months bleeding. This is a very common occurrence. It's not an uncommon occurrence, particularly the clinician space. The evaluation protocol was to be given associated. These are the cases where BMI is related to that. Associated obesity, BMI is absolutely related to this type of abnormal in the cycle and the flow. And of course, the hirsutism. Classical example is fitting into the criteria of a polycystic ovarian disease, and response to drugs has to be done for that. Already whether she is responding to the previous drugs for that, and the treatment history, whether she has been already treated earlier with that, and therefore the investigations again. Sonography, you do it routine to evaluate an abnormality. Biochemical, we don't require to do other investigations other than the thyroid investigations, and endocrine evaluation is there. Biochemical, we can do at least a GTT for that if there is a family history of diabetic for that. Genetic evaluation, particularly in a case where there is a scanty menses and irregular menses, rarely there could be some of the disorder attributable for the genetic propensity or genetic correlation. And the brightest example is a mosaic Turner for that. This could be if it is not responding, it's continuing with that. Think of that in genetic. I think there you can do an additional endocrine evaluation of doing a follicle FSH estimation to find out there is a high hypergonadotrophic amenorrhea or abnormality. And therefore, the genetic is only indicated in these cases when there is no response is there, and you can find the secondary sexual characters are not very well developed for that. There you can think of, but think in your mind about this particular entity for that. Same thing in a case of heavy menstrual bleeding. I must say that you think of some of the cases of syndromes which is there for that. A coagulation disorder syndrome is there, but it's not responding to all hormones. It is there for that. Then in this case, say no to endoscopy, no place for endoscopy in this particular case for that. So the treatment modality here is that the expectant manner. Don't give anything, and a counseling should be there. But with counseling, our Indian girls and Indian mothers are not happy. They want every month bleeding. They don't want, like Scandinavian countries, the mothers want menses only when they desire a pregnancy. If you say that we don't want menses, just a withdrawal every 3 months, they're acceptable for that. But here, in country like India, in our setup, the woman wants regular menses. Regular, not only regular, normal menses, flow must be normal, and it must be absolutely on the day, every 28 days, and not associated with any pain, and the bleeding must be really satisfying to her, that whether it's within a 3 to 5 days for that. So I always say, I don't know how our women, our patients are happy. If more bleeding, they're unhappy. If less bleeding, they're unhappy. If the cycle is more, they're unhappy. If the cycle is less, they're unhappy. I'm still finding out we can be, as a gynecologist, assured that when we give a medication, absolutely normal flow, normal cycle, we can restore as far as normal is concerned for that. So expectant management, empiric versus definitive management for that also. And of course, counseling has to be there for that. And lifestyle modification is absolutely, when we think that is attributable for polycystic ovarian disease, this is important for that. And therefore, these are the cases weight loss has to be done. But the cyclicity, our women want a regular cycle for that. So for the regular cycle, you have to give some drugs for that. Majority of the cases, if it is a PCOD, they need a regular cycle of that. The problem with us is that the hormonal treatment is there for that. The hormonal treatment, we do the cyclicity. What hormones? The confusion starts. There are a lot of hormones at our level, COC, plenty of COC with the varieties of combination we have in our setup for that. So these type of cases with polycystic ovarian disease, with the abnormal uterine bleeding, like infrequent menses and scanty menses, what should be the drug of choice for that? So either you can give a COC, like a combination of ethinyl estradiol with levonorgestrel, we can give it, but ethinyl estradiol should be as low as possible, and 30 microgram is enough for that. If you give it 20 microgram, there will be a breakthrough bleeding for that. So 30 microgram will be an optimum value for that. And the alternative is that, what is the component in a case of Progesterone. The progesterone component starts right from levonorgestrel, norethindrone to the next generation, like a drospirenone or cyproterone derivative. So these are the two important, drospirenone, cyproterone, or a dynogest combination. So which one will select in this particular case? If there is a pain associated with the adolescent AUB, my first choice will be the dynogest combination with the ethylene. If it is not, then second I will look for the amount of hirsutism. If the hirsutism is up till the level of acne, I think drospirenone combination will be the treatment for that. If it is beyond acne, some amount of hirsute is there, cyproterone combination will be the treatment. This is the truth. This is the clinical picture and the clarity I'm giving you. Many gynecologists are confused, and as per their own mood or as per their pharma-initiated therapy, they start the treatment. But the rational therapy, you remember that if there is a bleeding with the pain, I think the first and foremost will be dynogest combination. And if the androgenic features is there, you find out the androgenic status. If it is a clinical androgenic status is up till acne, drospirenone combination is the most ideal, which is also very important that it doesn't cause weight gain. It is not androgenic in compound, and metabolically it is very good for that. Whereas if it is associated with more of androgenic component, more than acne, like hirsutism and all that, cyproterone combination is the drug of choice for that. So take it that this will be more rational as a therapeutic modality for that. So the take-home message, consider normal in majority of cases due to hypothalamic immaturity. PCOD, one of the important cause to be looked into it. Empiric therapy and counseling form an important role. Anti-androgens, insulin sensitizers like metformin, short-term COC is the rational therapy, but ultimately the weight loss is of paramount importance for that. Let's analyze the third case number 3. Mrs. Y, 25 years, para 1, vaginal delivery 2 years ago, bleeding PV off and on for 1 month, previous cycle 6 months, for last 6 months heavy menstrual bleeding, ultrasound evidence of normal pelvic scan, not responding to progestogens. It is not responding to progestogens. Why we treat it? Average built, no abnormality in general examination. Clinically, pelvic examination is okay for that. So what should be the approach to this particular case? The clinical dilemma here is that the previous cycles was heavy menstrual bleeding. Now 2 years is the last childbirth, para 1, and bleeding PV off and on since 1 month for that. So need for hematological parameters. What are the hematological parameters? Yes, there is definitely need for hematological parameters because the complete blood count is absolutely necessary for that. Need for endocrine evaluation. I think sophisticated need is not important for that. Need for endoscopy in 25 years is the last study with non-responders for that. Need for evaluation for endometrial status is absolutely optional in 25 years. If we think of tuberculosis could be one of the reasons, but we do not think of malignancy for that and the treatment modality for that. So hematological parameters, what are the hematological parameters? You do it. And in this case, hematological parameters has been done. Peripheral smear showing plenty of blast cells. Simple peripheral smear. You think that it could be uterine origin, but think beyond uterus that it could be something other than that, hematological thing for that. Reticulocytosis, refer to Department of Hematology, and then diagnosed as CML. So a CML presenting as bleeding is a very is not an uncommon occurrence for that. Many of the CML patients do present to the gynecological OPD. Then we diagnose it and send it to that, provided we have a mind and think towards non-uterine cause or non-pelvic cause. Other than that is particularly a systemic cause associated with it for that. So the take-home message, think pathology beyond uterus. Systemic causes to be ruled out, especially non-responders. This is one of the cases of non-responder to hormones. So think about it. No need of ancillary invasive investigations for that. Case 4, Mrs. F, 22 years, married 6 months, heavy menstrual bleeding for 3 months with petechial rashes over the limbs, normal sonography. There is an indication. If you think only about the pelvis, you don't find it. But if they think beyond pelvis, that there is a petechial recess, what should be the first approach to this case? Hematological parameters. Think of some platelet disorder. Total platelet count will be 30,000 in this particular case. So refer to hematological department, diagnosed as idiopathic thrombocytopenia. Purpura, treated with medical management of steroid, and patient will be okay for that. So think beyond the pelvis and beyond the uterus in this type of non-responders for that. So the take-home message is coagulation disorder are one of the causes of abnormal uterine bleeding. Clinical pointers like a rash or petechial rash is an important clue for diagnosis. Importance of tech versus touch. This is a clinical diagnosis and technology cannot help it for that. Mrs. D, 30-year-old, para 1, abortion 1, vaginal delivery 3 years ago, suction evacuation done 3 months back for 8 weeks of pregnancy, persisting bleeding, DNC done, bleeding continued, not responding to progestogens. These are the cases is not responding to progestogens. Ultrasound showed everything normal. Uterus is bulky, cavity is empty. There is no evidence of any RPOC which is found for that. Cavity empty, head necks are normal. What do you think of that? What should be the approach to this particular case? This is not a very uncommon case. You must have seen this type of cases in your day-to-day clinical practice, but need for hematological parameters, again, it should be there because the bleeding for last 3 months for that. Need for hysteroscopy. We do not find, suppose we find a suspicious lesion in a case where sonography demonstrate could be a residual product of conception, there is the diagnosis that need for hysteroscopy. Many of the cases we find that there is a biconate uterus, suction evacuation has been done, but the product is there in the other arm, which is not being evacuated for that. So there we do an ultrasound, we do find that there is a retained product of conception. There you do a hysteroscopy guidance. You do a hysteroscopy and find out that which cornu the residual production of conception is there and evacuate. The treatment is all right for that. But here the ultrasound evidence is normal, uterus is bulky, cavity is absolutely empty. So here you think that there is no place for hysteroscopy. If there is some doubt about the lesion in the cavity, then put a hysteroscope. Otherwise, you don't do it for that. Any other test is important, any other test. This is the only test. Think about this condition, serum beta HCG, and serum beta HCG. And therefore, did a serum beta HCG, it comes about 2,400 internationally. So think about these conditions in a case of reproductive age, abnormal uterine bleeding with the previous history of pregnancy, recent pregnancy with evacuation is a atypical case, not uncommon in clinical practice. Think about GTD. GTD should be thought of with this clinical background for that. And chemotherapy gives a predictable cure rate. And not only cure rate, it also averts from development of malignant component of GTD for that. And therefore, it's a jade nature's first cancer and men's first cure for that. And this is the treatment modality, not by hormones or progesterone. Tons and tons of progesterones are not going to help. Just think about this. This thinking is important for the clinicians for that. Mrs. X, 28-year-old, para 1, vaginal delivery 1.5 years ago, lactating. Frequent cycle for last 6 months, every 15-20 days, normal amount of bleeding, but it's bleeding. It is bothersome to the mother who is is lactating and last child, but it's 1.5 years. Average built, no abnormality on general examination, clinical examination, pelvic examination revealed nothing for that. So what should be the approach to this case? And need for sonography? Yes, I will do just a sonography. It's a non-invasive test for that to exclude any abnormality for that. Just is enough for that. Need for endocrine? No need for any endocrine evaluation. Need for endoscopy? A big no for that. Need for evaluation of endometrial status? Absolutely not. When the sonography is having a normal thing, there is no need for doing an endometrial status evaluation. You don't want to know whether it's a proliferative endometrium or secretive. How does it matter to the treatment component for that? And treatment modality is absolutely very simple for that. And there, the clinical evaluation is optimum. Clinical evaluation is optimum. No need for invasive investigation. At best, a sonography has to be done for that. And the treatment modality, each COC, give a cyclic. COC is the answer for that. The choice, duration, and these two are dependent on the clinicians as well as the patient. And result is absolutely fantastic for that. So these are the cases where apart from the regularization of the cycle, you can add to the contraceptive effect for that. Because the last childbirth is 1.5 years and 2 years ago, and this just is supplemental feeding for that, and it's not going to be much more affected. And this is the answer. And normal cyclicity with the result of affection of the contraceptive effect is important for that. Mrs. Y, 30-year-old, para 2, both cesarean section, heavy menstrual bleeding for 1 year, not keen for conception, mild pallor, obese build, for abdomen, nothing abnormal detected, post speculum examination, cervix is healthy, and PV examination, we don't find anything non-committant finding for that. So what should be the approach for that? Hematological investigation, yes, you do it, specific investigations, particularly for the platelet and the hemoglobin status for that. And sonography is important only to look into the cavity or any pathology in the myometrium, myoma like a myoma or adenomyoma for that. This is indicated for that. And of course, endocrine evaluation, there is a limit. You don't do it accepting the TSH for that. And place of EUA, hysteroscopy, and endometrial status is only restricted to non-responders. We don't want to do these hysteroscopy investigations when we find that sonography, a good sonography, reveals nothing abnormal for that. So the treatment options here is a medical management for that. And therefore, what should be the medical management? Hormones, choice, and duration. As in the previous case also, this case will also be very well dealt with the COC for that. The variation, number one, the duration also varies. This will also take care of the contraception effect, but also that. But if you consider vis-a-vis hormones and non-hormones, is the first time we give it. Tranexamic acid, if it's controlled, is well and good. And hormones is definitely going to give it for that. But no surgery. Surgical methods are not to be indicated for that. And the general management is very important for that. And therefore, the take-home message here, what should be there? Abnormal bleeding, not uncommon in reproductive age group. And heavy bleeding carries a health risk. And evaluation targeted to rule out organic cause for that. And clinical evaluation at times suboptimum. The main thing in addition to it, you can do a good sonography for that. Medical management is the priority. And what should be the ideal medical management? COC or the choice of hormones, non-hormones according to the endometrial HP status. No, in a 30 years, even endometrial HP status is not necessary, unlike in the perimenopausal age group for that. This is the rational option. The COC will not be the first line of action. First line, I will prefer this particular case, para 2, 30 years, previous to cesarean section, not keen for conception. And there many people do a hysterectomy chop off. No, it's not an indicator for that. Even you can give a COC for a variable period for that. But in this particular case, for a long-term thing, for 7 years, you put it and forget it. And therefore, insert and forget. And therefore, LNG-IUD is a rational approach in this particular case for that. So non-responders in this case could be an ormiloxifene could be there for that. And if surgical method, if conservative surgery is preferable to that, like endometrial ablation is preferable if it is a non-responder to medical management. Otherwise, the medical management should be the priority for that. Life without knife. Mrs. Jet, 45-year-old, para 3, all spontaneous vaginal delivery, bleeding PV off and on, 20 days. It's a perimenopausal bleeding and previous history of heavy menstrual bleeding for 1 year, average build, pallor, moderate degree, no thyromegaly. For abdomen, we didn't find anything. For speculum, cervix is paras, healthy, bleeding through os plus. Uterus, mid position, bulky, farm, mobile, furnace free. Sonography, bulky uterus, adnexia are normal. I think these are the cases where I don't agree with the report of the sonography, which is normally the radiological report for that. If our gynecologists do that sonography, it could be much better for that. And therefore, what should be the approach? Re-evaluate sonography. I must know what is there in the cavity, what is the endometrial thickness for that. 46 years, perimenopausal bleeding. I must find out the endometrial thickness. I must find out whether there is a small polyp or a submucous myoma for that. So re-evaluate the sonography. Hematological investigation as usual, the CBC and TSH is important. Any medication to arrest bleeding. I think these are the cases where the first line management is a non-hormonal tranexamic acid. Don't start any hormones before diagnosis for that, because this case, the first priority we want to exclude any malignancy or pre-malignant condition. And therefore, these has to be first excluded, then only we can do any hormones for that. So therefore, this is the example, and a perimenopausal need for endometrial biopsy is a must. And need for endometrial biopsy with hysteroscopy is superior than a blind diagnostic curettage. Another time before the hysteroscopic era, we were doing a diagnostic curettage. Now, endometrial biopsy with hysteroscopy guided, I think this is a very important step, additional thing in the current situation. And improving the general condition, you take a biopsy, and normally if you do a thorough curettage also, that is a therapeutic indication for temporary period. And therefore, by the time you build up the patient with iron and improving the general condition, and then decide for the definitive treatment, medical or surgical. I've already clarified if it is the endometrial biopsy comes as an ATPR, or it is a simple hyperplasia with corpus cancel syndrome. Surgery is the main treatment for that. Otherwise, we will give the medical management first. Failure of the medical management, we can do surgery for that, hysterectomy for that. And therefore, perimenopausal abnormal uterine bleeding, very common. Evaluation to exclude organic disease like malignancy, correction of anemia is one of the important parameters. And under adjunctive therapy, hormones should be avoided from the beginning. Don't give hormones for that. After evaluation, then you can put hormones like norethistron. After doing a biopsy, then you start with that. Waiting for the report, then you change anything for that. Measures to arrest bleeding is a tranexamic acid, you give it, and if it is not controlled with the bleeding also, you do a hysteroscopy and endometrial biopsy. That's more reasonable, more scientific for that. Vital to know the endometrial status here, and hysteroscopic evaluation is significant information for that. Appropriate medical management depending on HP. As I've already told, secretory endometrium, late secretory, tranexamic or ormiloxatin. Otherwise, you give a proliferative endometrium, only progestogens can be given, and irregular secretory COC can be a drug of choice for that. So need for hysterectomy, you must evaluate. I've already told if there is a corpus cancel syndrome or ATPR, the surgery would be the first line treatment for that. And if it is not that, medical management or any alternative methods for that. Endometrial ablation has to be done for that. Endometrial resection has to be done for that. Because I feel that whose fault is this? The fault is with the endometrium. The fault is not with the myometrium. The fault is not with the cervix. So why to remove the innocent cervix and innocent myometrium along with that? Remove the endometrium if the endometrium is defective. That is the rationality. That is the principles of treatment and policy of that. Another case, this is a case where 50 years, these are all clinical dilemmas which I want to find. There are a number of cases you must have found out. These are glimpse of few examples starting from adolescent till menopause. I'm giving an example and spreading my message that these are all clinical scenario and dilemmas where you can solve it. This is a menopausal woman and 50 years, para 2, 1 year ago menopause. Bleeding episodes twice, two episodes of bleeding. She is a known diabetic, she is obese, she is hypertensive, all fitting to the corpus cancel syndrome. And systemic exhaustion, we don't find anything. Post-speculum cervix is healthy. PV, uterus is mid position, bulky, fan mobile, fan is free, and a good sonography is important for that. Here again, bulky uterus, index of normal, endometrial, myometrial echo. This is a common thing presented by the stereologist for that. I don't agree with that. So first, my clinical approach should be there. A good, again, re-evaluate sonography should be there. So the principle is ideal sonography should be done in that. This is a case of postmenopausal bleeding. We have read that the postmenopausal bleeding, you do a sonography, what should be the cutoff limit of endometrial thickness, and then treatment accordingly you do it for that. Even evaluation is not necessary if the endometrial thickness is less than 4 millimeter for that, and the bleeding is controlled. So normally the cutoff limit is 4 or 5 millimeter endometrial thickness, and this is done. And nowadays also with the endometrial thickness, color Doppler is also included on that. If the color Doppler with endometrial thin endometrium, color Doppler shows abnormality, you must do a hysteroscopy and endometrial biopsy with that. If there is a repeated episode of bleeding, even with the endometrial thickness of 5 millimeter, you do a hysteroscopy and evaluation for that. No more the age-old fractional curettage in a postmenopausal bleeding. We do not want to do a fractional curettage. Even hysteroscopy is not routinely recommended in all cases where sonography can be very reasonably accurately defined that there is no organic pathology and color Doppler is normal, endometrial within the cutoff limit, and the bleeding is controlled. If the bleeding is more and episodic is that, then you need a treatment for that. Majority of these postmenopausal uterine bleeding, there will be senile endometritis and atrophic endometrium for that. And next, if there is a suspicion when there is an endometrial hyperplasia, which is evident by sonography, you do a hysteroscopy, and majority of the cases it will come as a polyp, endometrial polyp, and it's a benign endometrial polyp. Malignancy is not there. But you have to exclude malignancy. Where there is a repeated episode of bleeding, the endometrium is thick, irregular. We can clearly define, and the sonographic diagnosis can be well correlated with the histopathological diagnosis for that. And therefore, complex area, combination of the mixed echogenic area there with the irregular thickening and irregular margin, this could be evidence of endometrial malignancy for that. And therefore, hysteroscopy, there is a need for that. No more fractional curettage. Hysteroscopy, there is a need for that. Endometrial status is a value for that. If it comes as an atrophic endometrium, no treatment is necessary. Just follow up of the patient. Repeated bleeding, then you need a treatment for that. Otherwise, it is not being treated for that. So it depends on the episode of bleeding for that. And if the endometrial status, HPC status is abnormal in form of, say, if it is a polyp, benign endometrial polyp, forget about it. If it is a hyperplasia, this particular case, there is a corpus cancer syndrome. So it's diabetic, obese, and hypertensive. In hyperplastic endometrium, if it comes as a hyperplasia, I will resort to the hysterectomy in this particular case for that. And the definite treatment is either otherwise, forget, follow up, and more of medical management than surgical management. Only indications when there is a pre-malignant condition like a hyperplasia with corpus cancer syndrome, or with the complex hyperplasia with atypia, or there is an episode of bleeding which is not controlled. Even if the cutoff limit is within the reasonable limit, there is a place of hysterectomy. Surgery is the treatment for that. And therefore, the take-home message AUB an important cause of postmenopausal bleeding. Evaluation mandatory to rule out endometrial carcinoma more so in high-risk cases. Sonography targeted to cavity, endometrial echo, and now with the new generation of machines, it is very accurate. Correlated. Hysteroscopy evaluation is mandatory. HPF endometrium starts from atrophic, proliferative, hyperplastic, and carcinoma endometrium. And depending on this, the treatment modality will depend on the endometrial pattern, high-risk cases of corpus cancer syndrome, and persistence of bleeding. These all you take into account for definitive treatment of the hysterectomy. And of course, the patient's wishes and consultant's attitude are important for that also. But I must caution you, you cannot be guided by patient's wishes for that. Even in young age, if the patient is really worried about the bleeding, she will tell that do a hysterectomy, sir. Doctor, I need a hysterectomy because I'm puzzled about it for that. In resistant cases, last resort going to be hysterectomy or some alternative methods of hysterectomy. But as because you wished, you counsel it and find out consultant's aptitude is more important than the patient's wish for that. So therefore, I must say in the last, read less and think more. You don't, any case of bleeding, don't start any hormones or progesterone in the initial case. Any case of bleeding, you don't do a hysterectomy for the initial case. And therefore, you think about it, and I've given a glimpse of the theoretical background, the clinical backup, and the clinician's perspective and approach to the management, either a medical or a surgical for that. Thank you very much, Team Juventus and Sanjay.
Thank you very much, sir, for in-depth discussion regarding AUB.
Thank you.
Sir, there are many questions, but if you permit, we can take few questions, sir.
Yeah. I'm okay.
Okay. The first question is from Kata Akshita. She is from Pedapalli. She is asking for the reason of menstrual pain and causes before the period.
See, reasons of menstrual pain. Well, either it could be originating with a common pathology for that. If the bleeding is more and pain is also associated with that. See, mainly in the uterine, if you consider the pathological status, there are two things. One is a myoma and another is an adenomyoma. These are the two cases commonly encountered with pain as well as bleeding. But here, if the pain is predominant, then the bleeding we think about adenomyoma. If the bleeding is predominant in comparison to the myoma, in comparison to the pain, then it is considered as a myoma. But you see in adolescent girls and particularly in majority of the reproductive women where everything is normal and they came with pain. Then I have already read about the primary dysmenorrhea, which is there for that. Without anything also, there is no uterine pathology, the pain will be there for that. And if the bleeding is more, I think if the clots are there, there will be pain associated because the cramping pains will be there to evacuate the blood for that also. So take a proper history about that.
Yes, sir. The second question is from Sonakshi. She is from Kushinagar. You have already explained, but she is asking ki the term DUB is absolute or what is the purpose of DUB now?
DUB?
DUB is
Absolutely, you send it to graveyard. Now the new generation, old gynecological teachers will ask about DUB for that. But if you know, that's why I purposefully presented. You should know what is a DUB. And there are three criteria of DUB. When the classification of AUB is there, automatically DUB without any clinical pelvic pathology. That is DUB. And this DUB is now transferred from dysfunctional uterine bleeding to AUB-O and AUB-E. This AUB-O and E are nothing but DUB for that.
Yes, sir, yes. The now next question is from Nuri Ansar. She is from Lucknow. She is asking regarding the role of dydrogesterone in AUB.
Now, I think, thank you very much for the question on dydro, because dydro revolution is there for the last 1.5 years. And dydrogesterone is more often used in a pregnancy state and recurrent pregnancy loss and in pregnancy state. Now it has inverted into the gynecological. Well, dydrogesterone is also, I was also using a dydrogesterone before all this dydro evolution for that. So there, the dydrogesterone, we are using it particularly after endometriotic surgery. In endometriotic surgery, we give dydrogesterone from 5th to 25th day for 3 cycles, or from 11th to 25th day cyclically for 3 cycles following surgery, where we want pregnancy. If they want pregnancy, this can serve purpose that it can enhance, it can potentiate and augment the fertility. Second important is that it can arrest the progress of the disease to a considerable extent. But if pregnancy is not warranted, we do not give a cluster drug like dydro very short to either a medroxyprogesterone or a GnRH analog 1 dose or 2 doses can be given for that. But dydrogesterone is a very good drug as far as the pure progesterone. It doesn't have an estrogenic effect. It doesn't have an androgenic effect. And therefore, it causes tromoglandular synchronization. And therefore, dydrogesterone, if can be used particularly for adolescent abnormal uterine bleeding, to arrest bleeding for that, this dydrogesterone is relatively safe, that you cannot say that it is an androgenic, you cannot say that it is an estrogenic, and therefore it is a best suited drug in adolescent abnormal uterine bleeding. But as far as the bleeding, arrest of bleeding is concerned, dydrogesterone is not an effective uterine hemostat as compared to the 19 non-steroid as synthetic derivative. And that's why it's not a first-line treatment for that, but you can give this dydrogesterone and as a maintenance therapy for that in the second or third half of the cycle, but usually for it's not a good hemostat for that.
Yes, sir. Correct. Sir, next question is from Rudra Narayana Patel, Walangir. He is asking PID as a cause of AUB. He wants your guidance on this.
Pardon again.
PID as a cause of AUB.
Oh, PID as a cause of PUB. PID again is a misnomer term for that, inflammation for that. And therefore, PID particularly can manifest with abnormal uterine bleeding. And more so when the tuberculosis, which I have highlighted that yes, it's one cause of abnormal uterine bleeding for that. And inflammatory, see, for example, there have been a lot of cases where there is a correlation between the hysteroscopic finding with the bacteriological, microbiological finding of endomyometritis. So there, they have shown that hysteroscopy, we find a congested vessels in that. So here, there is definitely a link between the abnormal uterine bleeding with the PID, where it is associated with the endomyometritis for that. So specific endometritis, tuberculosis, non-specific endometritis is there. And therefore, I have already clarified while defining the DUB, endometritis inflammation, which has been suggested by the Virco, is there for that also.
Yes, sir. The next question is from Sayani Dolui. She is from Durgapur. She is asking the treatment for postpartum prolonged bleeding.
Prolonged bleeding?
Postpartum prolonged.
Postpartum, yeah, that very often is a challenge to the obstetrician. Postpartum bleeding, first and foremost, you exclude any pathology. You do a scan to find out whether there is something, maybe that a retained product of conception or a placental polyp. Think of about placental polyp, or there are cases which I have seen, a pre-existing myoma. So that could be a submucous myoma, which is there already, which has not been detected during the time of delivery, and they manifest. So exclude some organic pathology for that. And if organic pathology is not there, then you find that the sonography reveals normal thing for that. And here you can give the progestrogens. And here the progestrogens, either you can give a very effective progestrogens like 19-hour steroid group, or a progestrogen which is very, very comfortable or beneficial for the lactation. That means a mini pill which are giving it, the progestrogen pill, which we can give it, and that can be continuing for that will arrest bleeding, that will help in contraception, and that could be used for a longer period of time also.
That's all, sir. Thank you very much, sir.
Thank you. Thank you.
Thank you very much, sir.
Thank you, sir.
Thank you very much, sir.
Tech support, please stop the recording.
Thank you, Nilesh. Thank you, Sanjay.